Hello, my name is Dr. Dewan S. Raja. Today I will discuss about thyroid cancers. There are four major types of thyroid cancer. These are the papillary carcinoma of the thyroid gland, follicular carcinoma of the thyroid gland, medullary carcinoma of the thyroid gland, and anaplastic carcinoma of the thyroid gland. We may add one more, that is lymphoma of the thyroid gland. Thyroid cancer is the most common endocrine cancer. Annually, 15,000 new cases and about 1,200 deaths in the United States of America from thyroid cancer. Female to male ratio is 3:1. Papillary carcinoma is the most common thyroid cancer. Anaplastic carcinoma is the most devastating type, with worse prognosis. In a significant number of cases, the patient may die within 6 months due to anaplastic carcinoma of the thyroid gland. Okay, physical finding, nodules or swelling, but we have to note that not necessarily all nodule or swelling are cancer. Only a few percent of nodules are neoplastic. Tumor may be benign tumor like that of the benign adenoma, follicular adenoma, or maybe the cancer like that of the papillary, follicular, medullary, or anaplastic cancers. So we may get nodule. Cervical lymphadenopathy, this is a site of metastasis, initial metastasis. Hoarseness of voice because of involvement of the recurrent laryngeal nerve. Okay, so these are the physical finding. Risk factor may be unidentifiable, being a female, fourth or fifth decade of life. Obesity is a factor for the thyroid cancer. History of neck irradiation, specifically in the early life irradiation. And risk factor thyroid cancer, specifically medullary thyroid cancer, may run in the families with multiple endocrine neoplasia, 2A or B. Okay, it may be one of the component of it is the medullary thyroid carcinoma, and this is a cancer, so there is continuous mutation is going on, like RET-PTC, papillary carcinoma. We have also translocation here in follicular carcinoma. We have other genetic mutation like BRAF, MEK, ERK, AKT, like this. Also in medullary thyroid carcinoma, we have also RET. RET is also seen in many cases of medullary thyroid carcinoma. Okay, type, if you go to the type, papillary thyroid carcinoma is the most common type. Histopathology reveals papillary structure, fibrovascular stoma, ground glass or orphan any nuclei. This is very important. Orphan any nuclei. Schemmoma body, these are concentric substance in a tumor. It is not necessarily only in papillary type of thyroid carcinoma. It is also found in many other tumor like that of the meningioma. Will get schemmoma bodies. Papillary thyroid cancer has better prognosis than other thyroid cancer. Follicular thyroid cancer, some of the follicles are encapsulated, relatively uniform follicles. Capsules or venous venule may be invaded by the cancer. Metastasis typically to the lung or bones. Okay. And it is difficult to differentiate follicular thyroid cancer from follicular thyroid adenoma. In case of follicular thyroid cancer, it will invade the capsule and venous venule. and it may go to the lungs or bone. Certainly, it will go initially to the cervical lymph node. So, invasion of capsular venous venule indicates this is follicular thyroid cancer, not follicular thyroid adenoma. In follicular thyroid adenoma, that is a common benign tumor of the thyroid gland. In that condition, there will be no destruction or invasion of the capsule. Medullary thyroid cancer originates from the parafollicular cells of the thyroid gland. So it is not from the follicular cell, from the parafollicular cell. So technically it is not the epithelial cell. It is the C cell or parafollicular cell produces calcitonin and other hormone. Okay, that may lead to Cushing syndrome like fidget. Okay, so sheets of cell with amyloid stroma may be sporadic in 70% cases or familial in 30% cases, like that of the multiple endocrine neoplasia syndrome. Lymphoma, B-cell lymphoma associated with long-standing autoimmune thyroiditis, mostly Hashimoto's thyroiditis. Anaplastic thyroid carcinoma is the worst of all in terms of prognosis. Okay, we look at some of the histological picture that has been taken from Robin's basic pathology. We have one reference, not two. Okay, one reference here. So here, this is the papilla we are seeing. This is papillary, and here is the papilla. One papilla here, and the papilla is here. And we look at the nucleus. Nucleus seems to be empty. Okay, homogeneous ground glass appearance. It is important. The particular well-formed papilla aligned with cell with characteristic empty appearing nuclei. Nuclei seems to be empty here. Okay, and what else? We'll also get nuclear groove in the nucleus, nuclear groove, and we may get nuclear inclusion. You get inclusion inside the nucleus. So it's important for papilla. We'll have papilla formation, and we have the cellular follicular cell will be changed, and nucleus will be like ground glass with some groove, and we'll find out that empty appearing nuclei, sometimes termed orphan N I nuclei. So these cells may be aspirated by fire needle, and we can study that. Okay, okay. So we got the papillary thyroid carcinoma. We have to remember papilla, and papilla contain fibrovascular tissue as a stroma here. We'll also get this type of cell with empty nuclei. Okay, and these are called orphan N nuclei. It may also contain some inclusion. Okay, this is the picture of papillary thyroid carcinoma. History, maybe childhood irradiation history. It is found that people living in the nuclear explosion area like that of Chernobyl, Russia, or maybe it may be in the Ukraine, most likely in the Soviet Union, the Chernobyl, and also you have to know that the Fukushima nuclear plant, due to tsunami destruction in Japan, people living in that area has more incidence of thyroid carcinoma, particularly papillary thyroid carcinoma, which is the most common type. Okay, so we got there follicular thyroid carcinoma. We can see the follicle with colloid. This is the colloid. Okay, and we found that we must find follicular thyroid carcinoma. It should invade the capsule and blood vessels, and it may be metastasis to the bone and the lung, certainly initially to the cervical lymph node. Okay, this is the medullary carcinoma of the thyroid gland. Okay, we found that here we'll get the amorphous substances Okay, so this is homogeneous. Okay, so thyroid gland tumor typically contain amyloid visible, where homogeneous extracellular material derived from the calcitonin molecule secreted by the neoplastic cell. So these are the amyloid here. These are the amyloid. This is amyloid. Okay. In medullary thyroid carcinoma may be associated with that. It may be sporadic. In 70% cases, it may be familial, like in multiple endocrine neoplasia, type 2, A and B. Okay. Around 30% cases of the medullary carcinoma of the thyroid gland. Another 70% is sporadic. Diagnosis of thyroid cancer: we have to do thyroid function test. Sometimes there is some hyperfunction, as in follicular thyroid carcinoma. Okay, so we look at the T3, T4, TSH level. Plasma calcitonin is a marker for medullary thyroid carcinoma. Thyroid scanning with iodine 123 or technetium 99M. This will assess the cold area or tumor area in the thyroid gland. Thyroid ultrasound is very important to diagnose. Fine needle aspiration. These are the diagnostic tests. Treatment depends on the nodule, if it is one nodule or multiple nodule. Depending on that, it may be total thyroidectomy or partial thyroidectomy, or partial one-sided thyroidectomy and removal of the isthmus and exploration of the cervical lymph node to find out any type of spread or metastasis to the cervical lymph node. So it is also supported by the radiotherapy, thyroid cancer. Okay, and that's all about the thyroid cancer. If you have any question, please feel free to ask me. Please share the information with your friends, and please support my channel. Please subscribe me. Have a nice day. Bye now.